So what we'll be trying to focus over here in the part that I'm talking about is how we try to ensure that EDI work was structurally created and how we were trying to actually ingrain it into the working work of the OHT. And that's what I will try to focus on in terms of the engagement. When the Central West OHT identified equity as one of the strategic priorities that they want to move ahead, they had defined that we needed to start with the terms of reference. They constituted the EDAC. They got in a resource, which was me, and they had like a clear-cut ideology in terms of how they want to move forward. So one of the key things that they did was establish an EDI framework, which was adopted from the existing resources out there, including the Ontario Health EDI framework that exists, and like the other frameworks with the hospital, William Osler Health System, Trillium Partners, and we came up with that framework. And then they had the EDI charter. But the key was to ensure that once we have these foundational pieces, how do we go ahead with this? So when we reached out with the EDI framework, everybody was keen to know, it's great to have a framework, but how do we practically implement this? That's when the EDIAC and other members identified the health equity impact assessment as the tool that the Central West OHT would use to ensure that we are able to embed the activities with an EDI lens. And that has been something that the Central West OHT has been utilizing to take the work forward. And we went about engagement at different tables. The experiences at different tables have been sometimes very dramatically different, and sometimes have followed similar paths. So I'll talk about a few examples over here. The scope group, we had an opportunity to engage with them, present our framework, present the EDI charter, present the health equity impact assessment tool. They had a lot of questions. They came back to the Equity Diversity Inclusion Advisory Council. They spoke at length. We had a couple of discussions, and I remember like there were some specific questions related to how scope would focus on the patient journey or like highlight what patients feel. And this scope program is specifically a program that is utilized by primary care providers, that they are the end users. It's not exactly the community. Like whether through scope is a program that primary care providers can reach out for fast tracking diagnostics and imaging processes, or if they need additional support to consultants. So it's the prerogative of the primary care providers. So there was very minimal scope to ensure that we were taking feedback from the patients, because there was no mechanism over there. And one of the feedbacks from the EDIAC was to ensure that at some level we are able to capture that, and scope is working on that, because it's not a directly correlated in terms of bringing that DEI lens over here. Priority population is another example. I've dedicated an entire slide to that. I'll be talking about that in the next slide, but it is almost 18 months of work that we had with priority population. Governance is an example where we had a very, very different experience. We presented our framework to the governance working group, working committee, sorry. And we had the framework, we had the health equity impact assessment, we answered questions, what they had in mind, and then there was a discussion. And what happened after that was static silence for a long, long time. But what we need to realize is sometimes the work that is actually happening is like when we present the opportunity to use tools, there is work really happening in the background. And one of the key results that directly came up at a later stage was the fact that the EDIAC at inception was an Equity, Diversity, Inclusion Action Committee. But from there, the governance really worked towards constantly in terms of developing it. And today, the Equity, Diversity, Inclusion Action Committee has been established as an advisory council. It is one among the 3 advisory councils to the Collaboration Council. And that's been a fundamental change in terms of how this work is proceeding within the Central West OHT. It kind of gives you where the leadership sees equity, diversity, and inclusion work, and the need to engage further and prioritizing the EDI work in what they do. The Collaborative Quality Improvement Plan group focused on multiple things. We had the opportunity to engage with them. They had the opportunity to come to the EDIAC, present their work, get feedback, go back. I'll just like to highlight one of the key areas where they're focusing on, like, because I cannot go on every aspect of it, but we have like a cancer, one group within the Collaborative Quality Improvement Plan, which is focused on cancer screening. They have today come together. The three organizations have collaborated together. They are defining which areas to specifically focus, and they have taken an India lens on that. We have high priority community strategy groups, organizations that are focused on that, which are highlighting, taking the EDI lens and very specifically focusing on communities to take this forward. So these have been engagement processes over a period of time, maybe not necessarily linear. There are different opportunities that present, and then sometimes things might seem static, but there is movement that's happening. There are undercurrents that are happening. And what I would like to say is the role of leadership in this is very, very crucial, whether it's the people who are sitting at the EDIAC or the people who are actually engaging with other leaders within the OHT, within and the different organizations that the OHT collaborates with. So that has a huge impact in terms of how the results finally pan out. One more example is the communications team within the organization at the OHT itself. We had different opportunities where the team really came and presented the different communications that we have. So the communications team really consults with the Patient Family Advisory Council and the Equity, Diversity, Inclusion Advisory Council to ensure that we are able to present to the community what we are really trying to do and present it in a manner which is accessible. One of the highlights that EDIAC had provided in terms of its recommendation was being AODA compliant. There has been a strong change in terms of how we have been striving to become AODA compliant. It's still work in progress, and the journey continues. Another set of group that I would like to highlight over here is the OHT partners in terms of the health equity journey that they had. So as we identified the health equity impact assessment, I do remember that simultaneously there has been an impetus, a focus from the Ontario Health in terms of getting the health equity impact assessment as a focal point. And I do know that as on today, if you are submitting an Ontario Health proposal for any funding opportunity, they mandate the health equity impact assessment to be completed to take that forward. So we've had opportunities to work with some of our partners, one of them being William Osler Health Systems, for specifically for their remote monitoring program for in respiratory care, where they wanted to bring that about. Virtual urgent care had another proposal, where we had the opportunity to work with them in terms of the completing the health equity impact assessment. Another partner, Keynes, who was focused on bringing in more alternate level care beds and ensuring that they ease out the ALC beds strain that is there within our catchment area. We had opportunities to work with all of them. Something that I would like to highlight is it's not happening in the most ideal way at this point of time, where we have these partners probably coming in terms of the stress of budgets and the timelines that they have in terms of turning around a proposal. They probably co-design the whole proposal and then they reach out to us in terms of taking forward this process. But I would say this is step one, and we still have an opportunity to engage when we are going through the health equity impact assessment to provide recommendations and the top leadership to really look into it in terms of understanding and scoping the project, even though they have completed the process initially. But it's still an opportunity where those ideas are implanted, and I would still take it as a win when we are getting these opportunities. The priority population, which was mentioned on the previous slide, but I really wanted to highlight this story over here very specifically. This journey of the priority population in terms of this is our priority population, the older adults experiencing frailty, was identified by the Central West OHT 18 months back. They constituted a working group then to come forth with a strategy, a solution to have an impact within this community and really help the community to take this forward. It is an 18-month long journey where they went through an engagement process, identified the causes, took up an population health management approach. They have engaged with RISE at multiple opportunities. I see there are some coaches from RISE over here. They would know that they were part of this journey as we were trying to take this forward. And as the health equity lead over here, I had the opportunity to engage with this working group. I had the opportunity to present the framework. I had the opportunity to bring forth the health equity impact assessment tool, and had a constant engagement with the co-chairs, with the working group ongoing. Like, it wasn't really just the presentation of a framework and the health equity impact assessment, but it was an ongoing engagement. It was an opportunity to keep socializing the concept of health equity and taking on that lens to ensure that we have a very robust program. And the results, I would like to focus first. As on today, we have a pilot phase that has been launched, and the program is already taking in patients on a pilot basis. And one of the eligibility criteria includes social determinants of health, and they have included this as part of the frailty screening itself. So as part of the frailty screening, normally they have cognitive, physical, and medical conditions that are considered to be part of any program for frailty. But the Central West OHT care program, focusing on older adults experiencing frailty, has included social determinants of health like social isolation, food security, to be part of their initial frailty screening, which means that if a patient would qualify for this program, if they have like one cognitive, one physical issue, or maybe 3 out of those, and if one of them is a social determinant of health, they still qualify for this program. And that has been a huge game changer in terms of how we look at supporting the older adults experiencing frailty. And I call this really a success story, because not just because of what you see on the screen over here, but also because of inputs that have started coming in terms of how the clinicians are recognizing the fact that those who would not have been part of this program had social determinants of health not been reported. And if you're not measuring that, and including the patients within this program, there would have been patients that would have landed up directly at the emergency room because of the lack of care and the slip that they would have had within the system. So as I move to the next point, which is evaluation, we have also included an EDI indicator. We just have one EDI indicator at this stage because this is a pilot phase, and we'll be reviewing, the evaluation team would be reviewing this when it becomes a larger program, and probably include more EDI indicators. Currently, the EDI indicator that has been recommended is measuring how many patients are being part of this program because they have a social determinant of health influence within the frailty factor. And that's something that we feel that we will be able to highlight very strongly as we go forward, and make this really a key program within the Central West OHT. One of the areas that the EDIAC has always focused on was the equity-based data collection. And this is one thing we have very strongly achieved through this program. We are collecting social demographic data right at the intake, and so that's the success part of it. Now I want to focus on the challenges that we had and the way this journey went ahead. As I said, it was an 18-month long story. The story still continues. The journey is still ongoing. It wasn't like we presented the framework, we presented the health equity impact assessment, and everything worked. So for full transparency, I need to let you know that this is one program where we have not done the health equity impact assessment, but still we see the results. And the results are because of constant engagement, constant socialization, and sometimes the leadership really coming forward and providing strong support. I realize that one of the key partners to implement this program is also a leader who's part of the EDAC. And that really helps us because they bring forth that view. And it's not an independent journey. Like I remember like a little earlier, Mona was sharing that we had 4 training sessions, 3 hours long each for our leadership. And there were, the way we had planned the sessions, we chose to slightly deviate from those sessions because there was so much sharing over there. The sessions were so intense, but the result has been that leaders across the OHT have identified this as a key criteria in terms of taking forward our OHT work and establishing this very much at a fundamental level, that any program that is coming out of the Central West OHT or being defined or co-designed at the Central West OHT will have this equity focus in taking this forward. So it's not exactly just a straightforward engagement that has resulted in these 3 success that I highlight over here, but it is really the overall journey that the Central West OHT has gone through in bringing this over here. So I would like to share some learnings and challenges. I'm focusing more on learnings, patience and persistence. As I said, throughout the journey, whatever we have done, there are times when we have faced a lot of pushback, and pushback is not always very straightforward. Pushback, no one really comes to us and tells us, we do not want to do health equity work or equity, diversity or inclusion work. We don't want to do this. No one is going to say that, but it's the nature of questioning that happens where some roadblocks are created. But I understand that leader engagement and education really helps take our cause forward. Providing relevant data helps to take this forward. Repeatedly engaging with them, and sometimes engagement means going to the meetings. Sometimes it means being part of the meetings, but not really presenting it every time, but being patient enough to have the opportunity to bring it on when it really matters. And the real success happens when, like, the person designated to bring up the EDI work doesn't really have to speak. Like, there are other members on that working group or working committee or the subcommittee who are really speaking up and bringing forth that lens. And that's something that I would say we are very, very proud of now, that engagement has happened. There have been certain focal points which has resulted in this, but that's beginning to show up very, very clearly across different tables. And a highlight has been a strategic planning process that the Central West OHT has been taking up. And I'm very confident that it's been showing up over there. The different leaders are speaking up. It's not the EDAC chair or the EDI lead or a member of the EDAC committee who's bringing it up, but it's different leaders across the spectrum of the Central West OHT collaboration who have been bringing up the EDI work over here. The next point is fluid approach. We might have a plan, we might have a process. We want to do it in a particular way, but it doesn't really work that way. Priority population engagement is one of the key examples. Like, I was pushing very hard, the EDAC was pushing very hard for the health equity impact assessment as a tool to be engaged. Didn't happen that way, but what we realized is over a period of time, the approach was different, but the results did come through towards the end. We had to push, we had to advocate, we had to bring in the leadership to talk to people, but it does happen. Changes, we have to be flexible about how we go. And strong leadership, as I have mentioned multiple times, leadership plays a very, very critical role in taking this forward. We've had very strong supporters, strong advocates, and I feel like most of the EDAC is always in an advocacy mode to get this point across. Socializing the concept, it's not just engagement, but having the opportunity to sometimes just socialize, let it out there, and then reap the benefits at a later point of time. And this is always work in progress, and we keep striving. We have created an action plan over here, and we continue to strive and bring the intensity much forward, take it on and engage much more in depth, and have much, much better results in terms of how we take this forward. The challenges have always focused towards project timelines, budget, and definitely a strong cultural shift that is needed to take this work forward. Thank you so much. It's been a pleasure sharing our journey with you, and I hope to continue learning with everyone.